All right, so tonight we are going to start with, we're going to talk about immunity. So this is our first bit of material that's going to be on your final exam, exam 3. So we're going to start with just kind of like an overview of some different types of immune-mediated disorders that we may see in some of our patients. So these are your learning objectives. All right, so the first thing we're going to talk about is some of our allergic disorders. So when we think of an allergic disorder, we know that these disorders are characterized by a hypersensitive type of a response to a weak antigen that is usually harmless in most people. Because they're usually harmless, what we see in people that have allergies is that they have this hypersensitivity reaction, okay? We wouldn't expect that these things would normally cause an issue, but sometimes it causes a more of a increased reaction than we would expect. And then, of course, we have allergens, and allergens are just going to be those antigens that cause these allergic response in our patients. And when we think of these different allergens, we have a couple different types. So we have ingestants. So these are a lot of things that we eat, okay? So there's a lot of common foods that are known to cause different people problems. So eggs, shellfish, milk, wheat, peanuts, some of our antibiotics as well, okay? So some of those common reactions can just be GI issues. It can be a mild skin disorder, just some asthma, some mild asthma symptoms, or it could even be hives all over the body, facial swelling, which is angioedema, and then, of course, anaphylaxis, which we know can be life-threatening. Then, of course, we have inhalants. So that can be a variety of different things. So these are going to be things in our environment. So it could be dust, it could be dander from animals, pollens, fungus, things like that. Then we have contactants, which are going to be our topical medications, some of our occupational chemicals that we might work with, cosmetics, metals inside of jewelry, things like that, hair dyes, latex. And then we have injectants, and what falls under that is going to be your drugs and your bee venom. So when we know the allergens, different things that can cause a reaction, so some of the reactions really are going to depend on each particular person. Everybody's very different how they respond to different allergens and things like that. So you could just have an allergic rhinitis, which is just sneezing, itching, nasal congestion, runny nose, redness, things like that. We like to treat those typically with, antihistamines, nasal decongestants, steroids. Then patients can develop a contact dermatitis. This is where it's a little bit more, involved, maybe some itching, some burning, redness. They might have a rash on their skin or wherever they came in contact with that allergen. And then, of course, for, how we would treat those is we would obviously tell them to avoid those allergens. They can wear gloves. We can treat with topical or oral antihistamines, and then corticosteroids as well. Then we have dermatitis medicamentosa, which is just a very quick onset of a bright red rash, okay, itching, a little bit more involved with the symptoms, fever, body aches, headache. And then, of course, we see this a lot with our drugs. So we would discontinue these medications, give antihistamines, and if it was like a topical-ish response, we would give topical corticosteroids. Then, of course, we have food allergies, and we could see a lot of different things with that. We could see anaphylaxis, depending on how severe it is, cramping, a lot of GI issues, which makes sense, nausea, vomiting, diarrhea, belly pain, itching, wheezing. And then depending on how advanced that is or severe it is really going to depend on the medical management. It could just be discontinue eating that food. Maybe we're giving some Benadryl, or they might, if they're not, if they're not protecting their airway, they might have to be intubated, okay? Urticaria is going to be itching, swelling, redness. It's those hives, okay? So urticaria is our nursing word for hives. And then, of course, we can give oral antihistamines, corticosteroids, oral and topical. And then angioedema is going to be itching, swelling, redness of our mucous membranes, typically in our face. So obviously thinking about this being close to our airway, depending on how severe it is, we may be intubated, we might just be getting medication over the counter. This is a picture of angioedema right here. One of the medications that you will see as a nurse, lisinopril, is a very common medication that we get for blood pressure, but I have seen many, many patients come through my unit that I've cared for that have had these very severe allergic reactions. I've seen patients that have had to be intubated because of this, and it's not when they initially start to take the medicine. So for every patient that I've ever cared for that had a reaction to lisinopril, they had been taking this medication for at least 10 years. One lady had been on it 22 years, and then all of a sudden she developed an allergy to it. So that is something that you might see in your practice. All right, so thinking of this pathophysiology and etiology of our allergens. So usually when we are exposed to something, we have what's called a sensitization. Okay, we really don't have any symptoms that first time. We don't know that we're going to have an issue with it. Okay, then what happens is we're re-exposed to that again, and then we develop this hypersensitivity reaction. Okay, and the thing about allergies is that they can be immediate. We can see reactions right away. They can be very mild or very severe, or they can be delayed several days. All right, so an immediate hypersensitivity response is going to be due to those antibodies that are interacting with those allergens, and it happens very, very fast. So we can have a type 1, a type 2, or a type 3. So your type 1, it can be an anaphylactic, okay? And these are typically mediated by your immunoglobulins, okay, and your antibodies, and these are the most severe. So definitely want to know this slide. So type 1 is going to be your most severe. Type 2 is going to be what we would call cytotoxic. These are mediated by our immunoglobulin M or G, okay, not as severe. And then type 3 is going to be our immune complex, which are mediated by IgG antibodies again. And on the scale of, the most severe to the least, going from type 1, they get less severe. So type 3 is obviously less severe than 2, and then of course 1. Then we have type 4. Type 4 is our delayed hypersensitivity response. So this is where these antigens in the body are initially going to be phagocytized by these macrophages. Okay, those macrophages are going to be those sensitized T cells that are then going to go on and then produce these cytokines that cause this inflammatory reaction. And what we see is that because of that initial response from the macrophages, they don't see this response right away. It can be several hours or several days, even more than a week or so, upwards of 2 weeks sometimes you can see a reaction. All right, so what do we have as far as being able to suppress allergic responses? So we have something called an eosinophil chemotactic factor, which is our ECF, and this is a chemical mediator, and this comes from the mast cells in our body. And what happens is we have this process called chemotaxis, and this is where the body attracts these migratory cells to a particular area of the body to try and stop this process. Then, of course, we have medications that we can give. We can give epinephrine and we can give corticosteroids. So epinephrine is going to interfere with that process on releasing of those vasoactive chemicals from those mast cells. So it's going to act on those mast cells and keep them from releasing that vasoactive chemical. And then, of course, we know our corticosteroids are going to be those anti-inflammatory hormones, and they're going to work by blocking the synthesis of those prostaglandins and those leukotrienes. All right, so definitely want to know assessment findings for anaphylactic reactions and our less severe reactions. So anaphylactic reactions, shock, okay, because we have this systemic vasodilation, so we don't have proper blood flow to our organs. Laryngeal edema, wheezing, stridor that you can hear without a stethoscope. You don't even have to be in the room to hear that. Tachycardia, because we have this massive vasodilation, so the body's trying to fix things. Maybe some general itching, hypotension, bronchospasm, and then angioneurotic edema. So thinking about that facial swelling. Some of those less severe reactions are going to be watery eyes, increased nasal and bronchial secretions, a lot of sneezing, maybe some vomiting and diarrhea, some hives, okay, urticaria, those are our hives, some itching, maybe some localized redness, and then people can develop what we call allergic shiners, and these are those dark areas under the eyes. All right, so what would we do to diagnose these patients? So we can do something called a RAST test, which is a radioallergosorbent blood test to see what type of allergens they have. Usually what we do is we send them to a dermatologist and they'll do skin testing. Typically what they do is a scratch or a prick test, okay? So they can inject these patients with a variety of different allergens to see if their body's going to react with them. They can do a patch test or they can do an intradermal injection test. What we really see a lot is that they do this skin testing like you see on the right, and they inject them with a lot of different things, sometimes upwards of 50 to 75 different allergens. And if they have this red reaction or they develop any type of a hive, then this would be considered a positive test. And you can see at the bottom, that's going to be that intradermal injection test where they just inject these things just under the skin, and they see if any localized swelling or erythema appears, and then that's going to be a positive sign. And then we can always do elimination diets too. So if a patient says, well, I never have milkshakes and I had a milkshake for dinner and then I broke out with facial swelling, we could try to just eliminate that and see if they ever have any issues again, okay, things like that. All right, so what do we typically do to treat allergies? So really it's going to just depend on how severe the allergy is. So we commonly use diphenhydramine over the counter, which is Benadryl. That's a great thing that works very well. We can also use Sudafed, which is pseudoephedrine hydrochloride, also sold over the counter. These do very well for giving immediate relief to patients that are suffering from allergies and kind of maintaining them on the long term. We can also do something called desensitization. So desensitization is something that is really up and coming. It's been happening for many, many years, but a lot more providers are starting to do this now. And this is what a form of, they call it immunotherapy. So for example, if you had a patient who had an anaphylactic reaction to peanut butter, what they would do is try to desensitize them from this allergy. So they try and get their body used to being around this peanut butter and not have a reaction. So what happens is the person would go in weekly or twice weekly, and they would get injections of that allergen that were very, very dilute. Okay. And as they go along, this could take upwards of a year or more. As they go along, they're going to increase the concentration of that allergen. And this is going to desensitize them to it so that they can live without having to worry about these anaphylactic reactions. And then they can also do a sublingual swallow immunotherapy. This is something that your book talks about. You don't need to know it for your exam, but it's a very special test, and that is done in a dermatological center. All right, so nursing management. We know we need to know this because we're nurses, so we need to know what nurses need to do. So always, always educate our patients that if they think they're having a reaction to something, that we want to remove their rings from their fingers, okay? We should be looking at this. We should be educating our patients that have allergies about this because we're worried about cutting off circulation, okay, if they start to have swelling. If your patient is going to be scheduled for some type of a diagnostic skin testing, we really need to educate them that they have to avoid taking any prescribed or over-the-counter antihistamines or cold preparations at least 48 to 72 hours before testing, because we don't want anything to suppress that response. We really want to be able to find out what they're allergic to. If their allergies are severe enough that they need to use an EpiPen because of an anaphylactic reaction, it's imperative that we educate the patient that they should always be carrying the pen with them, maybe one or two, not just one, that they should always bring it with them. They should know how to use it, and their family members and care providers should also be instructed how to use it as well. If they are going through that desensitization, we would be, if we worked in that outpatient setting, we would be responsible for administering those doses. And then, of course, they usually stay in the facility for a little while afterwards because we're monitoring them to make sure that they're not developing any type of a severe reaction. And then, of course, we want to do a lot of education for not just the patient, but the family as well, to avoid teaching what to avoid and how to reduce exposures. All right, so now we're going to talk about some of our autoimmune disorders, and you will see a lot of patients in practice that have autoimmune disorders. All right, so when a patient has an autoimmune disorder, what's happening? The pathophysiology is that these killer T cells and these autoantibodies basically attack or destroy the body's own natural cells. So part of our immune system is to recognize what belongs to us and that what doesn't belong to us. And if it doesn't belong to us, then the body is programmed to try and eliminate it and get rid of it so it doesn't cause any harm to us. But with patients that have autoimmune disorders, the body doesn't work and they can't tell that that the things that they're destroying belong to the body. So they destroy their own natural cells. So we have these autoantibodies, which are antibodies that against these self-antigens. They're usually immunoglobulins. They target those histocompatible cells in the body, which are those cells whose antigens match the individual's own genetic code, which means that it belongs to them. It's not foreign. So we categorize or diagnose someone with an autoimmune disease when they develop these, different disorders that have this unrelenting, progressive tissue damage for we can't find a reason for. Okay, there's no verifiable etiology. So we've done a lot of tests. We can't tell what's causing it. It's progressive. We're seeing damage. It's chronic. It's unrelenting. So that's when they get diagnosed with these autoimmune disorders. So some of the autoimmune disorders that you may come in contact with, some of the most common ones are MS. We did talk about that. Multiple sclerosis, acute glomerular nephritis, rheumatoid arthritis, and systemic lupus. All right, so these are some of, I'm not going to read these. You don't need to know these for your exam, but these are some of the theories that they believe that surround the development of these autoimmune disorders. So, assessment findings. The symptoms are really going to depend on what autoimmune disorder they have and what tissues and organs are affected. So this is not a one size fits all. You're going to see a variety of different things. Typically what you will see though is that these symptoms are very characteristic of a person that's having an acute inflammatory response. And what you'll see with these autoimmune disorders is that they're chronic and they are progressive and they alternate between periods of remissions and exacerbations. So they can go, months, years at a time without really having any issues. And then all of a sudden it can, rear its ugly head again and they can start having problems with it. So just like we think about COPD or diabetes, things like that, these diseases have these periods of remission and exacerbations. How long these periods are going to last, these exacerbations, we don't really know. It depends a lot about the severity of the disease, what type of disease it is, the health of the patient. Okay, and then acute exacerbations really have these pretty concrete, significant, recurring types of signs and symptoms. And of course, those signs and symptoms are going to be very different for each type of disease. All right, so how would we diagnose a autoimmune disease? So we can look at a lot of different things, but one of the things that we look at is an ESR rate, and this is an erythrocyte sedimentation rate. So we can look at this ESR, and it's going to measure the amount of inflammation in the body. So typically these patients that are diagnosed with autoimmune disorders have a very high inflammation rate in the body, okay? You definitely need to know that for your exam. We can look at they have something called anti-streptolysin titer and anti-nuclear antibody titer. These are just other things that we can look at to see if they have a positive response, and rheumatoid factor as well. You don't need to know that for your exam, but these are our different types of tests that we can do. And then once we diagnose them, so some of these what you'll see with a lot of these is that they require you to have, this positive finding, like maybe a high ESR rate, and then 2 or 3 of these symptoms. So if you look up lupus requires you to have at least 5 of the possible 13 types of side effects that you can be experiencing in order to diagnose it. So it is pretty specific. And you'll see that with your other types of autoimmune diseases as well. So what do we do to treat these patients? So we've talked a lot about these immunosuppressive patients, right, over the past several months, about how we always have to monitor them for infection because they're taking medications that suppress their immune response. So these are those patients now that take these medications. So we would give them medications that are going to calm down that that immune system, because the immune system is not working properly. So we can give cyclosporine, which is a very common medication. We can give tacrolimus, which is Prograf. We can give cytotoxic agents, and we can give corticosteroids. So with our immunosuppressant agents, this is great that it calms down our immune system and puts things at rest and gives relief to the patients. But we also know that we're putting them at risk for what? What do you think that we need to monitor in these patients? So if you said infection, you're absolutely right, because now we're manipulating the immune system and we're decreasing how effective it can work. So we're technically solving one problem, but now we're putting them at risk for developing another issue, okay? These cytotoxic agents, some of those obviously don't just target the bad parts of the immune system, they kill everything. So there's a whole issue of, different side effects that come with that, thinking about your chemotherapies. And then, our corticosteroids are great, right? Because they're going to interfere with that inflammatory process. But we know that taking these long term are going to cause a lot of issues. So we know that these patients are at risk for developing edema and swelling. They're at risk for developing an infection. They're at risk for developing diabetes because it increases their cortisol level, which increases their blood sugar. We know it puts them at risk for developing osteoporosis when they get older. So a lot of different side effects come with these. So as part of your nursing management, what do you want to do? So there are some familial components that we see to these autoimmune disorders. So we always want to make sure that we get a good family history. Tell me about your parents. Tell me about your grandparents, brothers, sisters. Have they ever had any type of an autoimmune disorder? Of course, we're going to be looking at vital signs. We're going to be definitely examining the patient to see, can we visually see any signs of localized inflammation? Are they having issues walking? Are they having joint complaints? Like, are they having trouble with their ankles and their knees and their wrists and their shoulders? That could be like a rheumatoid arthritis. And then we want to assess their energy level, because these autoimmune disorders can be extremely debilitating. And then, of course, we're going to look at our laboratory findings, and then, we're going to be looking at that ESR rate to determine if they're exhibiting high levels of inflammation in the body. All right, so next we are going to talk about chronic fatigue syndrome. So chronic fatigue syndrome is going to be basically this profound fatigue that doesn't have any type of identifiable cause. We can't figure out what's happening with it, okay? So fatigue worsens with physical activity and it does not improve with rest. So no matter how much sleep they get, if they stayed in bed for 2 weeks, they are going to be even tireder than before they went to bed, okay? We don't really know what causes this. We do see that with some of our patients, when we do testing on them, that they have a history of developing different viral infections, and that these patients have a deficiency in adenosine triphosphate, which is ATP, which we know we need in our body and our cellular activity to make energy. So, assessment findings. So, these patients will present flu-like symptoms, okay? Even possible symptoms of an upper respiratory infection. So malaise, very, very tired, achy joints, achy muscles, headaches, okay? They might complain that they've gotten headaches before, but this is a new type of a headache and that it's coming very often, very severe. Might have a sore throat, maybe tender lymph nodes in the axillary and cervical area, joint pain with or without redness, unrefreshing sleep. So these patients will say, I have slept for 14 hours and I'm more tired than before I went to bed. Severe ongoing fatigue that worsens after physical activity. And then this fatigue is going to be so debilitating that it interferes with this patient's ability to be able to go work outside of the home. Okay, so they might report that they're missing a lot of time from work. They're not able to keep up with their expectations, in their personal life. And then we know because of this fatigue that it's going to have an impact on our brain function. So there's going to be significant impairment of them being able to have a good working short-term memory and to be able to concentrate. All right, so diagnostic findings. We might not have anything, they might not report any significant past medical history. We might not be able to see anything on an examination, okay? Client may have other physical or psychological conditions as well. We're going to do a lot of different blood tests. So we can look at our blood urea nitrogen, we can look at our calcium, we can look at the thyroid, because thinking back to hypothyroidism, these patients have a lot of fatigue, right? So we're going to try and basically rule a lot of things out to be able to make this diagnosis. And then what we will see is that we will exhaust all of these medical workups, and we'll be able to say with certainty that you don't have this, this, and this, so you probably have chronic fatigue syndrome. All right, so how are we going to manage these patients? So we're going to treat based upon whatever their symptoms are, okay? So if they're complaining of pain or they have a fever, we're going to give them aspirin, acetaminophen, Motrin, things like that, even Aleve, okay? Low doses of tricyclic antidepressants, because we see that these medications can relieve their pain and help improve their sleep, okay? Just definitely educating these patients to, we want them to balance their activity with rest. So, if you're going to do something for 2 or 3 hours, then rest for 2 or 3 hours. Definitely keep up with your physical, being physical, being active, go to the gym and work out, because we don't want you to develop muscle atrophy. And then we want them to be able to avoid overexertion, because this is going to exacerbate their symptoms. All right, so nursing care plans. So related to fatigue, they might need some help to perform their activities of daily living. We should schedule rest periods every hour or more, okay? And then outcome for these patients would be that we would expect that their fatigue will be reduced so that they're able to now participate and manage some of their activities of daily living. For chronic pain, we can apply cold or warm packs to those affected joints or muscles, encourage them to float in a tub or a pool. So we don't want really, really hot temperatures for this. This is important. So hot tubs, things like that, too hot. This can further exacerbate the body and put the body at a state where they can develop even more symptoms. So we kind of want a tepid water, about 85 degrees. And then, of course, that outcome would be that the patient, the client pain is going to be reduced to a tolerable level. All right. So that is caring for clients with immune-mediated disorders. Now we are going to talk about patients who have an immunotype disorder, which is going to be HIV and AIDS. So these are your learning objectives. So when we think about these patients that have immunoacquired immunodeficiency syndrome, okay, AIDS, which is very different than HIV. AIDS is going to be an infectious and definitely a fatal disorder that really compromises and weakens our immune system to the point that the patient basically succumbs to some type of an infection, okay? HIV, which is human immunodeficiency virus, is going to be the pathogen that patients develop that will eventually, if left untreated, develop into AIDS. Okay, so AIDS is still considered a pandemic. It's estimated that about 1.7 million people in the world as of 2019 had HIV, but this was a decline of 23% in new HIV infections since 2010. So that's phenomenal. There were approximately 38 people across the globe, okay, with HIV in 2019. We see that this occurs in homosexual men and women, IV drug users, heterosexual women, healthcare workers. Okay, so healthcare workers, this is something that we are susceptible to. This is something that's transmitted through bodily fluids. So in 2019, around 700,000 people died from AIDS or an AIDS-related illness worldwide, compared to 1.1 million people in 2010. So that is a decline in mortality of 39% since 2010, which is phenomenal. So through education, better medications, medication compliance, we are really making an impact in this disease. So there's two types of two types of HIV. There's HIV-1, which is the most prevalent type of HIV that we see in the United States. This mutates very, very easily and very, very frequently, which is why it's so prevalent. There's HIV-2, which is less transmittable. You have this longer interval in between when you develop this virus compared to when this virus can turn into AIDS. And we do see that most of the cases of HIV-2 are going to be found in West Africa, which is the primary site of these infections. So, what are the structural characteristics of this virus? Because it is a virus, it's not a bacteria, okay? So what we see is that these cells are genetically incomplete, okay? So they are surrounded by this double layer of lipid material, okay? Inside of them are a couple different enzymes. You don't really need to know what's inside of these, but I want you to have a good understanding of how this process works, because the medications that we give work on these different areas, okay? So inside these enzymes, we're thinking about these enzymes are going to be your protease, your reverse transcriptase, and your integrase. And these all play a very important role in how this cell divides, okay? Then we have our T cell lymphocyte fusion, which is going to connect our HIV to our T cells, okay? And then these are going to call, we have medications now that are called entry inhibitors. These are medications that we're going to talk about that keep this process from happening, keeping that connection process from happening. All right, so what is the role of our helper T cells in the immune response? Do you remember? Because we've been talking about this over the past year. So we know that our helper T cells are supposed to recognize those antigens in the body, and then their job is to go to those B cells and then basically stimulate them and tell them, hey, I need you to produce more antibodies to fight this off. Okay, so in simple terms, that's what our helper T cells do. So we have different replication enzymes, and these are important in that replication process. So when we think about this virus being able to replicate, this is what's involved in that process. So we have reverse transcriptase, and in this process, what's going to happen is that they're going to copy the viral RNA to viral DNA, okay? Then we have the process integrase, which incorporates that now viral DNA, and it's going to put it into the host cell, into our own DNA. Then we have protease, which is going to free those replicated viral particles into the cytoplasm of the cell. So these are the three main processes that we see for this virus replicating. So how do we transmit? How is it transmitted? So you definitely need to know this. Body fluids, okay? Blood, semen, vaginal secretions, breast milk. And you definitely need to know who are those high risk factor people to develop this. So unprotected sexual intercourse, okay, that's a big one. Multiple sex partners, sharing IV needles, having a non-autologous transfusion, so getting a blood transfusion from someone that you don't know, obviously. And an infected mother can then transfer that to her infant child. So we also need to know this. How are we going to teach patients to prevent the development of HIV? Well, abstination is great. So abstain from sexual intercourse, have mutually monogamous sex with an uninfected partner, okay? Avoid casual sex with multiple partners, avoid unprotected sex, use a condom and spermicide, okay? During sexual intercourse, abstain from using IV drugs, and then when you're using IV drug, if you are using IV drugs, you want to get a new needle and a syringe each time. You don't want to share these with other people. And then thinking about obviously many, many reasons to abstain from using IV drugs, but some of these medications that these patients use causes them to have disinhibition and hypersexuality, which puts them in a position to engage in some of these unsafe practices. Refrain from donating blood if you're engaged in high-risk behaviors. And then if you're in a position to donate your own blood before a procedure or something like that, that's definitely something that we recommend. All right, so AIDS. So we're going to talk a little bit about the development of AIDS. So AIDS really is the end stage of HIV infection, okay? You do have to meet a criteria to be able to have a medical provider say your HIV has now transitioned into AIDS. So what do we look at to determine if a patient now has moved from HIV to AIDS? So we look at their T4 cell count. So we monitor their T4 cell count throughout early diagnosis and then throughout their treatment. And we're going to talk a little bit more about that. But when we see this T4 cell count get below a certain level, that tells us that you now have transitioned to AIDS. But we don't just look at that T4 count alone. So these patients have to have this markedly low T4 cell count, and they have to have developed one type of either an opportunistic infection, which we see an opportunistic infection is an infection that we typically see in a population like this that are so immunosuppressed that they develop this infection, okay? It can be a type of cancer or it can be an opportunistic infection. And then we can classify these patients category 1, 2, or 3, or A, B, and C. So this is an important slide. I'm not going to read all of this, but this really explains to you this transition of going from HIV to AIDS. So just quickly, category A, a T4 cell count greater than or equal to 500. Okay, this is going to be AIDS. This is going to be HIV. Then if we have a T4 cell count of 200 to 499, still HIV, okay? But once that T4 cell count gets less than 200 and they develop one of these things listed in the right column here, they have now transitioned into this diagnosis of AIDS. So I would definitely study this and know the categories and the, those defining factors for diagnosing someone with AIDS. So this is just a little bit of pathophysiology here. So This virus is going to impair the ability of those T4 cells to be able to recognize things in our body. So we can't recognize those foreign antigens anymore, and we no longer can stimulate those B cell lymphocytes. So we can't protect our body anymore. Okay. The rate of progression, that's really going to depend a lot on when they were diagnosed and if they're taking medication and if they're being compliant. So, what will we see with these patients? So, a lot of, they might complain with some swollen lymph nodes, a lot of fatigue, okay? Tender lymph nodes, they might develop some pharyngitis, they might complain of muscle pain, joint pain, fevers, okay? Fevers with unknown origin, they can't figure out why they're getting them, and maybe even a rash. Some of those opportunistic infections that we're going to talk about are going to be Kaposi sarcoma and pneumocystis. All right, so how do we diagnose this? So we can do an ELISA test, which is, we call this the enzyme-linked immunosorbent assay test. So this is going to detect HIV antibodies, okay? So we do this test a lot. If we really want to diagnose it with a positive result, we don't want any false negatives, we will go to a Western blot. So a Western blot really is that gold standard, okay? This is going to determine the antibodies specific to HIV. If they have a reaction to at least 2 antigens, this is going to tell us that this is a positive result. So once, this is not the first test that we go to. We'll do these other tests first. There's a couple different ones out there. There's quick ones that you can do at home that involve kind of like a blood sugar test. You can come in and get this ELISA. If you've gotten a positive result from these tests, then that's when you're going to go in and have this Western blot. So this Western blot is going to be that confirmatory test that confirms these previously positive screening tests that we've done. Then we're going to take a look at the total T cell count, right? Because we need to try and figure out where these patients are. Do they just have HIV, or have they maybe been ignoring these symptoms and now it's progressed to AIDS? So a count of less than 500 indicates that we have some type of immune suppression, okay? A T4 cell count of less than 200 or less is now that indicator of AIDS. A lot of different other things we can look at. We can look at viral load. We can do a P24 antigen test, a polymerase chain reaction test. What I want you guys to know about this is that these tests are going to be instrumental in guiding the drug therapy. So what type of medication are we going to give these patients? And it's also going to dictate the progression of the disease. So if we do viral load, say someone comes in, they have a very high viral load, we start giving them this drug therapy to suppress this. If we check them again in 6 months and they have no viral load, technically they still have HIV, but that means that they're not showing any signs of the disease, which is what we want, because we know if we can keep them to not showing any progression of this disease, that we're going to increase the time period before they could possibly develop AIDS. And now with the medications that we have, with the regimens being better, the side effects being better, it is not uncommon that patients diagnosed with HIV today live the remainder of their lives, well into their 8th or 9th decade and don't have any issues, because we can diminish this viral load. Okay, where many, many years ago, it was just so new and we didn't know so much. This was a death sentence for many people. And of course, we can look at different cancer screenings, and then of course some pap smears in women. Oops. All right, so how are we going to treat them? We're going to give them an antiretroviral drug therapy that's going to target those viral enzymes. So remember when we said back a couple slides ago about these different enzymes that do these different processes inside the cell? We're targeting them in these different areas of the cell to stop that replication process. So we're not just hitting it from one direction. We're hitting it from all the ways that this virus can replicate, which means that we have to have multiple drugs. Okay. What is the problem with this? So drug resistance, and then drug cross resistance, of course, is a problem. Other things we see, we're going to be, how we have to treat these patients. We can look at their CD4 count. We would treat patients that are pregnant differently, okay? Some of these patients develop renal disease. We have to treat them differently. So there's a lot of different things that go into this. So we definitely need to know this. So what we call this drug regimen is heart therapy. So it's heart therapy, but it means highly active antiretroviral therapy. So we have here 4 different ways of treating that HIV. So these medications here listed first are going to interrupt that reverse transcriptase phase. Okay, this is going to be your NRTIs and your NNRTIs, and you should know these medications. So if I give you a medication, Fusion, you should know that this is an entry inhibitor. Okay, if I give you Incestrus, you should know that it's an integrase inhibitor. So then you have your protease inhibitor, your entry inhibitor, and your integrase inhibitor. So these medications will work in each stage of this replication. And then we have new types of medications now that are combinations, because if you think about, and we've gotten better with our heart therapy, but it used to be that they would take upwards of 13 to 15 medications a day. Now we have it down to 4. For thinking about compliance and things like that, taking 4 different medications or 6 different medications 3 and 4 times a day, we know that compliance is not going to be very well for some people. So we're doing what we can to try and make this medication regimen easier so that we see more compliance. So we have this combination therapy now, and that would be your Atripla, your Stribild, and your Truvada. Truvada I see all the time. I don't see the other 2 so much. So where do these drug therapy work? So it's showing you right now in this process of replication where it keeps this virus from being able to replicate. All right, so we worry about drug resistance. So drug resistance occurs when these HIV viruses develop mechanisms to be able to outsmart the medication and to be able to survive, okay? So when drug resistance develops, it affects the way that it's going to respond to those medications that we have. Those medications are no longer going to work, or they're not going to work as effectively. Drug resistance limits the ability to contain that disease, and it makes people more susceptible to spreading this disease and them developing those opportunistic infections. So, what advice can we give these patients? We want them to be educated about compliance. We want them to take these medications exactly as prescribed. So we know we're going to make sure we talk to them about side effects, because if they know about these side effects ahead of time, hopefully there's things that we can implement to make those a little bit less, to keep them taking the medication. They should never omit or delay any doses or stop taking these medications without consulting a physician. And like I said, monitoring that viral load is going to be very important. So these patients have to make sure that they keep their appointments to have these frequent blood tests. So what are the goals of our drug therapy? Really, we want to keep that CD4 count above 350. If that CD4 count is above 350, then they're getting close to having an undetectable viral load. And that is what we want in these patients. We want that viral load to be undetectable. We can also give different adjunct treatment therapy as well. So for some of these patients that develop these opportunistic infections or these certain cancers, we can give hydroxyurea, which is Hydrea. This is used to treat Kaposi's sarcoma, and then we can give these cytokines. So cytokines are helpful because they're going to work to boost the effectiveness of the levels of these antiviral drugs. Okay, so your interferons will make these antiviral drugs more efficient, and then the interleukins that we will give them will stimulate their body to make more lymphocytes. And then, of course, we have been working on an AIDS vaccine, a lot of clinical trials going on. Haven't seen that come to fruition yet, but it is something that we are working on. All right, so we're going to talk a little bit about these opportunistic infections. So one of the opportunistic infections that we see these patients develop is pneumocystis. So this is a type of pneumonia, okay? So Depending on, the health of the patient and how severe it is, really is going to depend on how we treat them. So it could just be mild and it may just respond to some antibiotics. We might give them some Bactrim. Of course, maybe some suctioning, because with any type of pneumonia, we're thinking a lot of secretions. Maybe some of those bronchodilators, things like that. And then if it's severe enough, they might need to get a higher level of care in an ICU and be on a mechanical ventilator that breathes for them. Candidiasis is that yeast infection, okay, that we see a lot of our cancer patients get because they have that decreased immune system. So what would we do for these? The most popular thing that we do is nystatin pill or liquid form. We can do vaginal tablets as well for women if they're getting yeast infections, and we can do suppositories as well. So, this is going to be a Candida albicans is a fungus infection. So we're going to give an antifungal. Another opportunistic infection is cytomegalovirus. So signs and symptoms of this would be blindness, okay, so big change in their vision, ulcers that develop in their esophagus, very big, painful ulcers, colitis. It's going to affect the lining of their lungs, so they're going to develop pneumonia, have definitely difficulty breathing. And then encephalitis, which is an infection inside the brain. And we have a variety of different medications that we would use to treat those, and they are listed on your slides. Another one called cryptosporidiosis or cryptosporidium. Signs and symptoms of this are going to be very loose stools that are relentless. So a lot of diarrhea. That diarrhea is then going to lead to dehydration. And, of course, we know what's going to happen then. We're going to have electrolyte imbalances. So we are going to be doing stool samples for these patients. And we're going to be testing for ova and parasites because that's what causes this. And the treatment for this is going to be Zithromax, which is the zithromycin, or Humitin, which is paramomycin. And then we have something called an AIDS dementia complex, ADC. This is where infection turns into AIDS and it causes a rapid degeneration of the brain. So this degeneration of the brain is going to cause very severe symptoms in the patient's mood, their cognition, their level of consciousness, and their motor function. So they're not going to be able to participate in their activities of daily living, walk, talk, feed themselves, things like that. The medication that we can give to help with this is called Namenda. Then these patients can also develop something called digital sensory polyneuropathy, DSP. This is where they develop these different abnormal sensations in their different extremities. So burning and numbness. So kind of similar to neuropathy that our patients with diabetes get. So we could give them some Elavil, which is a tricyclic antidepressant, and we can also give Neurontin or gabapentin, which is an anticonvulsant, but we're using it for the neuropathy. So nursing management, what do we want to do? We definitely need to educate our patients about HIV prevention strategies. Again, we talked about a lot of them, but definitely safe sex practices or sexual abstinence, definitely diagnostic screenings if someone thinks that they've been in a situation and they might have developed AIDS, recommending those diagnostic tests, counseling. There's a lot of counseling and a lot of community resources. Talking to them about their antiviral drugs, about how compliance is so important. So we know if we want compliance, we have to teach them about those side effects, different things that they can do to reduce those side effects. So a lot of teaching there. And then, of course, we want to put them in touch with support groups in the community, with other people that have this as well, that can be a source of hope and support for them. Obviously, from a nursing transport, we know that we're at risk for developing this, so we want to reduce our occupational health. So we want to make sure that we're always following standard precautions, okay? We want to make sure that we're always handling our needles and our sharp instruments with care, paying very close attention. When we're transporting specimens and body fluids, we want to make sure that they're in leak-proof containers that are sealed well and the lids are on properly. We're always cleaning and disinfecting using our gloves, and then remove our barrier garments. Make sure we're disposing of them in the proper way. Client teaching. So definitely, we want to talk to them about that medication regimen. What does it look like? How many medications are they going to be taking? What times of the day do they have to take them? And what is the goal of this therapy? And we know that that's to suppress that viral load. Okay. We want to talk to them about maintaining or gain weight, because weight loss is something that they see early on. So we want to talk to them about their diet and monitoring their weight, drinking a lot of fluids, reporting weight loss to us, which could mean that things are not getting any better. Avoid exposure to people with infections. They should be bathing daily, keeping themselves clean. We don't want them to develop any type of an infection. Definitely, alternating those periods of physical activity with adequate rest periods. And then, of course, not sharing IV needles or donating blood. And then, of course, we know that there are a lot of ethical issues surrounding HIV. There's a lot of fear that if someone finds out that they have HIV, that they're going to be released from their insurance company, that their employers are going to, fire them from their job, that they're not going to have a place to live. These are real concerns. I would like to think that we know enough about this now that this is not as much of an issue as it was before, because we know so much about it. But I'm sure that unfortunately these things do happen. There is something called a vitactical settlement. A viatical settlement, which is where a patient that has AIDS can name a person as beneficiary to their life insurance in exchange for immediate cash. So some of these patients, when they develop AIDS, because of the cost of the different medications and the treatments and the care that they're going to need because they get so sick, they don't have the money to be able to provide for themselves. So in exchange, they can say to someone, well, I have this life insurance policy that's worth $500,000 when I die. I will name you the beneficiary, and then you would give me $500,000, and then I can use that money to take care of myself, during this period where I know I'm going to need a lot of care. And this is not something that we typically would just see, just between two people that just do it in the privacy of their own house. This usually is done through an attorney or some type of licensed insurance broker, so that way all of these stipulations are taken into account, so that, both people in this situation get exactly what's intended. All right, that is it. If you have any questions, do not hesitate to send me an email.